So I will turn the microphone over to Dr. Shing and let her share her screen, and we'll go with grand rounds this morning.
Thanks, Dr. Pat. Let me get this screen shared. All right, go into presenter mode. All right, you guys see my slides?
Yes, we do.
Okay. Yep. So I'm Elaine Shing. I'm one of the PGY3s here in the program. Today I'm going to be talking about management of recurrent traumatic shoulder instability in adolescents. I have no financial disclosures. I do have to say that this is a controversial topic, and so I'm hoping I can hit on some of the key points in the literature and generate some good discussion at the end. So I'm going to start with a case and then go through the natural history of shoulder dislocations, give evidence for two broad categories of our treatment options, and some evidence for whom and when to treat. So I was motivated to give this talk by a consult that I had when I was on call. I actually got called by the OBs about a 16-year-old female who was 2 days out from a C-section delivery. And she reported that she felt her left shoulder dislocate while she was pushing herself up out of bed. And she knew she had dislocated because she had a 1.5-year history of recurrent shoulder dislocations after an initial traumatic event. She said she had about 10 to 12 dislocations in that time frame. Her first dislocation was in April of 2019, and her most recent one prior to this one was in February of 2020. She ultimately had conservative treatment. She did a brief period of physical therapy from March to June, but then she stopped for about 6 months when she found out she was pregnant, and then dislocated again in December. She wasn't an athlete or anything, reported a baseline normal level of activity, and this was her dominant shoulder that she dislocated. So some questions that I had after seeing this consult, and that I would encourage y'all to think about as I go through the presentation, is whether or not we think that she quote unquote failed therapy. And at this point, how do we treat her now? Do we manage her with therapy indefinitely, or do we go ahead and offer her surgical stabilization? And had she presented to us after her initial dislocation, do we think we would have treated her differently? So we're all familiar with traumatic shoulder dislocations. They're actually fairly common injuries with an incidence of almost 24 per 100,000 each year in the United States. You can see here it's mostly young patients who are having these injuries, and adolescents in the 10 to 20-year-old age group are the second most common age group population to sustain these injuries. We think this is because we now have a greater adolescent sport participation, and it's often males who are sustaining these injuries, but not always. With recurrent shoulder instability, it also seems to be this adolescent age group between age 14 to 16, 14 to 18, who are more likely to not only have traumatic primary dislocations, but develop recurrent dislocation as well. So there's a study that came out of Canada looking at the pediatric adolescent population, found an exponential increase in likelihood of patients who are 14, 15, and 16 years old to, again, not only have primary dislocations, but develop recurrent instability as well. If we're talking about adolescent shoulder instability, I have to mention the Hovelius papers that came out of Sweden. He followed almost 250 patients who were between the ages of 12 and 40 at their primary dislocation event for 25 years, so really long-term follow-up. And he reported at 2, 5, 10, and 25-year intervals different outcomes, one of which was whether or not these patients developed recurrent instability. All of these patients were initially treated non-operatively. As we'll see later, some of them went on to require surgical stabilization because of recurrent instability, though. So at 2-year follow-up, again, he reported that it was the younger patients, so this adolescent, young adult age range, who was more likely than their older counterparts to develop subjective instability or recurrent dislocations. And the same was true at 25-year follow-up as well. This age group of patients who were between ages of 12 and 16 at initial dislocation were more likely to either still have recurrent instability or have needed surgical stabilization due to recurrent instability. compared to their older counterparts. He also reported that there were no differences in gender, activity level, or the presence of bony lesions at initial dislocation in predicting who was going to go on to develop recurrent instability. Somewhat in contrast, there was a recent meta-analysis in 2015 by Olds et al. That looked at 6 retrospective cohort studies. And they found a trend towards males being more likely to develop recurrent instability. About 50% of females developed recurrent dislocations, as opposed to about 83% of males who developed recurrent instability. This meta-analysis also reported that there was no relation to the presence of Hill-Sachs lesions in predicting which patients would develop recurrent dislocations, but patients who initially had Bankart lesions were more likely to develop recurrent dislocations. And just to note, there were only 2 studies who actually included bony lesions, so we have to kind of take these results with a grain of salt. So to kind of summarize the epidemiology, it appears that it's this adolescent age group, so between 12 and 14 up to about 18 years old, who are most likely to develop recurrent instability after a primary traumatic shoulder dislocation. Maybe males are more likely, maybe patients with bony lesions also more likely to develop these recurrent events. So when we're talking about treatment options, there are 2 broad categories: non-operative, which is the classic choice, which involves immobilization with or without rehabilitation. And then we have operative treatment options as well. There's actually not a lot of concrete data out there evaluating the efficacy of non-operative treatment for preventing recurrent dislocations. Dr. Rowe, who is a famous shoulder surgeon back in 1960, reported, it was almost like an observational study, really, but he found that patients who were immobilized for about 3 to 4 weeks had lower rates of recurrent shoulder instability compared to those patients who had no immobilization at all. And oh, by the way, he, even at this point 50 years ago, found that it was younger patients who were having more recurrent dislocation events. So he recommended that patients, young adolescents, be immobilized for about 3 to 4 weeks after initial dislocation. Hovelius, though, in his long-term follow-up study, said that immobilization versus immediate mobilization was not associated with recurrence rates. And then Dr. Rowe also advocated for starting resistance exercises in younger patients as opposed to in older patients. But in this particular paper, he didn't provide any data. There was a study back in the 80s that came out of the Naval Academy, which did evaluate in a prospective manner the efficacy of a non-operative treatment protocol for patients who had sustained primary shoulder dislocations. And they reported a 75% success rate at 3-year follow-up in helping to prevent the development of recurrent instability. So they concluded that it's important for young adults to be started on resistance exercises after they have an initial dislocation event. We actually have a lot more papers that compared non-operative treatment to operative treatment. One of the early studies came out of West Point and found that patients who were treated initially with conservative management after a primary dislocation ended up having a 92% rate of developing recurrent instability, as opposed to patients who were initially treated with arthroscopic stabilization. Only 22% of these patients ended up with recurrent instability. And these results were replicated in 2019 in a paper that compared arthroscopic stabilization to non-operative treatment at 4.5-year follow-up in a group of young adults. They looked at a number of outcome measures. They found that patients who were treated with arthroscopic stabilization at initial dislocation event were more or less likely to develop recurrent dislocations and had a longer time to dislocation event. They were also more likely to return to sport at the same level, and they scored better on a number of different patient-reported outcome measures. And then also radiographically, they were less likely to have signs of glenohumeral joint arthritis. And when they did have changes radiographically, they tended to be milder. These results were replicated and summarized again in a recent meta-analysis that looked at non-operative versus operative treatment of traumatic shoulder dislocations in young adults, and again reported that those who were treated initially with non-operative management had a much higher rate of developing recurrent dislocations compared to patients who were initially treated operatively. But with data interpretation, there's a lot of subjectivity involved. And so I want to go back to the Hovelius study and point out again, a different way to look at his results would be that 40 to 45% of young patients at long-term follow-up without any surgical stabilization don't end up with recurrent instability. So there's this great debate of whether or not after initial dislocation event, we should operate or not. Again, historical teaching is that we should treat patients conservatively, and we have some data to support the efficacy of conservative management. But we also have multiple studies that show that maybe going ahead and performing surgical stabilization after one dislocation in these adolescents is superior. But it's a 50-50 chance, kind of, at long-term follow-up as to whether or not patients are going to develop recurrent instability at all. So I personally think that a better question we should be asking is, who should we operate on? And there are some barriers to deciding and providing general recommendations. One, there's lack of consistency in the literature. We don't have consistent age demarcations or follow-up length or rehab and immobilization protocols being tested. We don't have consistency in how we define failure either. And then for providers who are interested in treating athletes specifically, there's very little literature on this subpopulation specifically. So just last year, what paper came out of the Mayo Clinic that attempted to create a tool similar to the TLIX for spine trauma that guides prediction and helps decide whether a patient is going to develop recurrent instability, and therefore whether we should treat them operatively versus non-operatively at index event. And this group identified 6 risk factors: age, sex, sport, hand dominance, bone loss on radiographs, and type of instability, and created a 10-point prediction tool. They applied this prediction tool to a group of adolescent athletes who were treated non-operatively. And they reported that patients who initially, based on their demographic characteristics and injury type, scored less than 7, had a 97% success rate with conservative management. They didn't develop any more instability. They were able to return to sport without additional injury. But those patients who had scored 7 or higher on this NICES tool had a lower rate of success with non-operative management. So this group is advocating for using this tool with a cutoff score of 7 to help decide which patients you would recommend operative stabilization to versus proceeding first with therapy and immobilization. So I think this is a good starting point. Of course, we can discuss some of the limitations of this tool, but I think it's a good direction that we're heading in the literature. So to revisit our case, and just to remind y'all, this is a 16-year-old female who sustained a spontaneous left shoulder dislocation after having about 10 to 12 dislocation events in the last year and a half. She was treated conservatively and went about 9 months without a dislocation after she started physical therapy. So to get back to my proposed discussion points, I think that she actually had she didn't fail therapy. She was treated successfully. And had she presented to me after her first dislocation, based on the fact that she did not appear to have a high risk of developing recurrent instability, I probably also would have treated her conservatively at that point. But I think the important question now is to ask, in this kind of a patient, do we think she's going to fall into this category of still having recurrent instability at long-term follow-up, or is she going to be in this category of patients who spontaneously heal and don't ultimately need surgery? I think personally that having had 10 to 12 dislocation events, I would probably recommend surgical stabilization. But I would love to hear from the audience what your opinions are and what your thoughts are as well. So with that, I'd like to thank Dr. Connor, Dr. Mormon, Dr. Hammond, and Dr. Rebo. Here's literature, and I'll open it up to questions and further discussion. Thank you.
Elaine, thanks for a great presentation. You know, it is hard to sort these cases out in these young patients. I would suggest that she's probably an atraumatic instability. You know, I think that's kind of the first major category. You know, bifurcation that you think about: are they traumatic? Are they atraumatic? And for the atraumatics, would agree that, and for the traumatics in the younger patients that aren't super athletically active or otherwise demanding as it relates to their activity level, would recommend non-operative treatment for them. But when you get to 12 dislocations, I think you'd consider that a failure of treatment, and then at that point, you would probably want to move ahead, even if it's a patient that is more in that MDI category. There's a good paper that was written a long time ago by Rockwood and Burkhead, looking at the success of therapy for different forms of instability, and they showed an 85% success rate for non-operative treatment for atraumatic instability if you were persistent with a good exercise program. Whereas for the traumatics, it was like almost the opposite natural history, where only about 15% of them were successfully treated with the rehab program. So those patients, we would get a little bit more aggressive with them earlier, probably, but still in that category after probably a second or third dislocation. Now there's a subcategory that you didn't get into a lot that they talk about at West Point, and Bob Arciero, Tommy DiBerardino, and Dean Taylor talked a lot about these folks, about a very aggressive approach after the first time dislocation. But they're talking about West Point cadets, and they're talking about, you know, high level football and collision athletes. And those folks, you can probably make a good argument, because the natural history there is that they have a 95% chance of recurrence, and you can actually reverse that natural history to 5% recurrence with early surgery. So it's really kind of shared decision making with the patient, and interested in hearing what the other experiences are. I know we got a lot of great shoulder surgeons, and got some great pediatric orthopedists on the call too. And John Rebo has a lot of experience with this topic, so anxious to hear what they have to say.
Well, T, this is John. Can you guys hear me okay?
Yes.
So first of all, Elaine, that was a fantastic talk, and a topic that's near and dear to my heart. And I see a lot of these kids, and you know, you don't have time in 15 minutes to cover the whole breadth of literature, obviously, but I'll tell you, I run the shoulder instability research group for the Pediatric Sports Medicine Society, and we just had a conference call last week on our research agenda and sort of publication agenda. And what I can tell you is that our number one priority is to convince more people to operate on first-time dislocations. And let me sort of put a little bit of background in that, is that if you're treating an adolescent, like T said, a collision athlete, a lacrosse player, a soccer player, a football player, their risk of recurrence is about as close to 100% as you can get. And the side of the literature that we didn't have time to talk about today is how poorly people do with arthroscopic surgery, at least if they've had 2 or more dislocations. So there's a great paper by Paul Saluin from the Cleveland Clinic I'd recommend looking into, where they looked at surgical success rates after 1 dislocation versus 2 or more dislocations. And basically, if you've had even 2 dislocations and you get an arthroscopic stabilization, your failure rate's 30 to 40%. And so there's really this window of opportunity to fix these kids and, like T said, reverse the natural history of the disease. What is sad is when I see kids who have had, you know, 5, 10, 15 dislocations, and they're 15 years old, and really you're thinking, does this kid really need a Latarjet? Do they need some more invasive procedure? And those are things that are non-anatomic, can have long-term ramifications for arthritis. And so I think there's a public health component to this, where we need to educate trainers and coaches and primary care physicians who refer us patients that when an adolescent dislocates their shoulder, they need to see a surgeon to at least have that conversation. And one of the sort of the best kept secrets about shoulder stabilizations in kids is that it's no different than doing it in an adult. There's no growth plate, concerns, you may use smaller anchors, but really, it's not like, I maybe shouldn't say this out loud, you don't really need a specialist to do it, right? I mean, any good shoulder surgeon can and should do it as long as you're careful with your technique. And so, both here at OC and more broadly, I'm very interested in spreading the word that there is value, once again, collision athlete, adolescent, and stabilizing them. The ones where the decision making is hard are the ones that are, perhaps a 14-year-old ballet dancer who has a freak accident, right?
Mm-hmm.
Is that somebody that you stabilize or not? And that's where the shared decision making comes into play. And I'd be curious to hear what Pat and some of the other, experienced shoulder docs on the phone think about some of those more nuanced patients.
This is Dana Pisacki here. I think I would just second what Jonathan and T had said. Elaine, that was a great talk. It is impossible to cover everything in shoulder instability with 15, 20 minutes. You did a good job, though. You came close to it. I think to Jonathan's point and to T's point, I think one of the reasons the literature can be a little confusing in this, and this is actually kind of a statement on our literature in general, because shoulder instability in terms of its natural history is something that is as well described as anything that we have in orthopedics. So this is about as good as it gets for us. And still there's controversy. And I think really what you see in the literature is lots of subpopulations that behave differently in terms of recurrence and what the significance of that recurrence is. The way I think about shoulder instability, and Jonathan's totally right. And if you look at the literature on adolescents, the recurrence rate, even with one-time dislocation stabilizations, is 24 to 30%. And I think activity level plays a major role in these patients in causing recurrent dislocation events. The reason you operate is to prevent recurrence from a quality of life standpoint, and also to try to minimize the likelihood that pathology that results from the dislocation will cause a worsening condition that, if needed for surgery later, would require a more complex and potentially more morbid operation. And then long-term health-wise for the shoulder, the Havilia study you mentioned definitely paints a picture of poor health for the shoulder that dislocates thousands of times over the course of a lifetime in terms of arthritis.
Mm-hmm.
I think, to Jonathan's point, there definitely has been an increased emphasis in the past several years on the downside of recurrent instability, but still the population matters. And if you look at the data, Hovelius's data, as you suggested, maybe upwards of 40, 50% of patients do not have recurrence. There's a study just this past year in high school athletes where they were allowed to return to play through the season and had a very low rate of recurrence, and that was across ages, gender, and sport. And so I don't know that it's 100% that these people are going to have dislocations, and it is tricky to tease through it. And I think you have to weigh the downsides of recurrence relative to the downsides of surgery. And surgery is not a panacea here, even for patients with uncomplicated instability where it's a soft tissue stabilization only, particularly overhead athletes. We know from the Moon database that only about 60% of those athletes are actually getting back to play after a stabilization. So there's a penalty for intervening. And we do have to weigh those factors, as we do with all the decisions we make in terms of recommending surgery. But I do think you can make a strong argument that, particularly for the higher risk athletes who are almost certainly going to have recurrent events, and particularly those who present with time zero bone lesions, which we do know natural history-wise do tend to worsen over time. And if they worsen over roughly 3 to 4 dislocation events, we know that often creates critical instability that frequently requires a more complex operation with increased morbidity and downsides. So I do think we have to have our antenna up for being aggressive in these patients, but you always still have to consider the patient. If they're not super active and they don't have any bone lesions on presentation, my personal approach, particularly in female athletes, is to give them an opportunity at least to get through the season. But it is a nuanced approach, and I think you can make it a case to be more aggressive.
I'll just chime in a couple of comments. This is PC and Lane, great job. And read the comments made. I will Madsen came up in follow-up from the study that Dr. Rockwood, acronym of the TUBS that I think most know. The traumatic functional dislocation require surgery, and those that are more operatively. And even now that also for the residents up on in training exams. I would say even the instability index score, which has been an effort to put some activity about, doesn't really start. So from a practical standpoint, if it's a traumatic dislocation, particularly in an athlete, depending on the age and the activity level, sometimes we'll get them through the season, as Dana mentioned, but almost always those patients in that shared decision-making discussion will have surgery at the end of the season, rehab, and be ready for the next season, and have a recurrence rate in single digits. If however it's somebody that just falls while they're skimboarding on the beach, and they're not really going to put themselves in repetitive and recurrent risk, then oftentimes those are successfully treated without surgery, as Hovelia stated. So I think everybody's points are really good, and Elaine, great job with your grand rounds.
Thanks, Dr. Connor.
So to that end, with whether you do the first one or not, and you see about bony lesions, if you look at, so I guess I'll ask the people that have chimed in, are you doing advanced imaging to look for labral lesions with that as well on those first-time dislocators, then to help you in the decision-making process of whether or not to intervene?
Yeah, I'll chime in there. I think to me at least, and this is I think probably a surgeon preference thing, whether there's a more substantial labral pathology really doesn't impact the treatment decision making for me. The location of the soft tissue injury, if it's off the humerus, makes a difference for me. I still personally think that a mini open approach for fixing that is valuable, and you don't want to miss that. I think many surgeons are doing that arthroscopically, which I think would also tend to not really matter for the MRI. The value of the MRI for me is really to look for either atypical pathology with respect to the capsules I mentioned, or in older patients, if you're worried about a cuff pathology that would impact your positioning at the time of surgery or surgical decision making. Advanced imaging, for the most part, really has more to do with imaging the bone, as you're alluding to, and there's good data that arthroscopic only evaluation and assessment of bone loss in the glenoid and the humerus is insufficient. And so a 3D CT scan with thin cuts and 3D recons, it really has become the standard of care. I think some centers are doing 3D MRIs, but most of us are doing CT scans in these patients where you think bone loss may be an issue, because it's been shown to be the most predictive or most accurate predictor of true bone loss, and it has been a good way to potentially alter your operative treatment plan.
Kevin, if you look at RCR's data, it's over 90% will have a labral tear after a first-time dislocation that's traumatic. So I don't know that it's necessary. I agree with Dana for that purpose. Usually I'm looking for bony abnormalities or associated labral pathology. Sometimes if this is a collision athlete, they'll have a greater than 180-degree labral tear, and Clyde Helms and Larry Higgins had written about that. And you might be a little more aggressive with that one if the biceps is involved, but really that's about the only thing I can think of that would change the course. You can get a pretty good idea of the bony deformity with an MRI and not have to send them for multiple studies. So I think if you are going to get a study, probably the MRI gives you the most information if you really are looking at a young athlete. Totally agree with Dana. For the residents, you need to know that a dislocation in a patient over 50 years old is associated with a 70% plus chance of a rotator cuff tear. So that's why you see us getting those in that category, as Dana mentioned.
Great. Well, Elaine, just as you predicted, there'll be lots of comments and discussion on this controversial topic. But thank you for a great review, and thanks everybody for commenting.